Welcome to Women Who Fights podcast. We empower female fighters to take full agency over their training. Our goal is to celebrate and inspire others with the incredible action women and allies are taking to level the playing field. We talk to experts, uncover prejudice, and champion what's driving our progress.
And this is the second part of a two-part podcast with Lea, who's a pelvic physio. In our last episode, we covered her own experience with concussion, as well as discussing a little bit about fertility, PCOS, and painful intercourse. We're really excited to discuss more about pelvic health with Lea. And let's start with a massive beast topic, which is perinatal care. So, what part do you play in helping women during this time?
Yeah,
And
great
talk to us
topic.
about it a little.
Yeah, of course. So this is probably one of the big specialty areas that I work with out of my private practice. And so we work on a variety of things during perinatal care. I always am one to be proactive about a woman's health. And so optimizing their pregnancy and postpartum is one of the best ways to start off. So even if they're not experiencing any issues, but just want to make sure they're doing the right things and setting themselves up for success. So usually, typically, when it comes to women who are pregnant, we tend to see them after their first trimester, but that's not to say I see them really early on. The only reason why I mention that is because for the first trimester, we don't do internal examinations just because it's earlier on and it's not contraindicated, but unless there is specific reasons, we try to avoid that. And so early on during their pregnancy, it's looking at their bladder, bowel, and sexual health, just as to anything we do with pelvic health, and seeing how everything is going. So whether or not, they have some urgency or some frequency with their bladder, or they're peeing just in case, some of those simple things that we talked about before. Now, I will disclose that as a woman gets to the end of her third trimester, it is normal if they're going to the washroom a bit more frequently because baby is growing, and so he or she will press on the bladder and you will get that sense of urgency. So later on that is okay, but so often when women come, they have things that have been pre-pregnancy and don't realize. And so it's the first time they've come in contact with a pelvic physio and learn, wow, I didn't know we could address these things. But again, even if they didn't have anything, it's looking at their pelvic floor and are they able to completely relax their pelvic floor and lengthen it? And are they able to contract and control that to have strong endurance, power, all of those things? So pelvic floor is one piece, the bladder piece I mentioned, and then bowels. Often during pregnancy, women are on iron supplements and constipation tends to arise. So it's about optimizing if they don't, but often they do have either constipation, hemorrhoids, anal fissures. And so any of that combination, there's a lot that can be done to help address those areas. And then the other piece that is so important, and in Canada, we have our Canadian Physical Activity Guidelines for pregnant women is looking at what kind of physical activity should they be doing. And yes, physical activity is important during pregnancy, and they have shown that. So it's not about stopping what you're doing. It's about trying to get 150 minutes of moderate activity throughout your pregnancy. Now, as you get closer to the third trimester, you may just be more uncomfortable. And depending on your level of if you're an athlete, for instance, you might be able to do more during your second trimester because your body's used to that level of intensity. But let's say someone who's never exercised, you're not going to go put them on interval training or some high interval HIIT training, for example. So it's very dependent on who that person is when they come in during early on in their pregnancy and then guiding them through just even physical activity. So that movement piece is so important. And I see so often women come and they're like, I'm pregnant, I can't do anything. And then they stop moving and then they get pain. And then there's this huge thing of pregnancy related pelvic girdle pain. And it's quite common in the sense, I can't remember the statistic right now, but a lot of women do experience it either during pregnancy or postpartum. And that is a big area under perinatal care that I see. And so I'll talk about what pelvic girdle pain isn't, because there's a lot of myths around that, and research has started to debunk it. And so there's a lot of this talk that, oh, your ligaments are lax and that your pelvis is moving and that everything's out of place. That has nothing to do with pelvic girdle pain. They have now substantiated that it is normal. You have increased relaxin, which does help to allow your pelvis to open in preparation for birth, which is incredible, that what our body can do when you think about it. But that has nothing to do with pain. It does not equate to, because you have more relaxin, you're going to have pain, because we know there's women who have no pain and they have the same thing happen to them. And so it's really just a region, whether it's the front of the hips, the back, the tailbone, your pubic bone, anything in through that region is what we classify of pregnancy-related pelvic girdle pain. And what they're starting to notice is really common is that it has to do a lot with pain science. So some of those similar concepts we talked about in the first podcast, so those lifestyle interventions, our hormone levels, so is our cortisol shooting up like crazy throughout the day? Because we know cortisol and stress has a huge impact on our pain levels and how that works. And our nervous system, so again, our diet, our sleep, our movement, our mental health, all of those play a huge role, and just understanding why there's pain and how we can change it. So a really cool trick that I learned, and is when one of my mentors, she talked about walking backwards. And so often now when I have pregnant women who come in and they have this pelvic girdle pain, I tell them, walk backwards. And then they're like, oh, I don't have pain. And the reason is it's a novel movement. So it's providing a new stimulus that the brain isn't associating with pain. And again, it's going to show that it's a bit more of that nervous system and giving your body a chance to move that isn't associated with pain. Now, there are some things that are also helpful. So looking at the pelvic floor, as I mentioned, a lot of women, as they're pregnant, they want to make sure everything's safe, or if they've had a miscarriage, for example, in the past, this is a big one where they're trying to protect their belly because they've had that association that, there's something happened traumatic in the past, or if there was sexual abuse or a traumatic birth experience in the past, there's a big correlation between previous birth and trauma and then pelvic girdle pain with the second delivery or second pregnancy, I should say. And so they're just like holding it on in through that region, but it's a subconscious thing for protecting, right? Our body is so good at protecting us, but sometimes it's just protecting us a little too much. And so it's about, again, connecting with the pelvic floor and seeing where we're at. And a big piece of that is pelvic floor remapping. And so going through the pelvic floor to say, where are we holding tension? And there's often a lot of times you see like hypertonic pelvic floors, and this goes into even pelvic pain conditions that we'll talk about afterwards. But you see, oh, I have a hypertonic pelvic floor. But it's not always a hypertonic pelvic floor. There's just tension in the pelvic floor. So what I mean by that is we'll do this pelvic floor remapping, and within a minute or two, you'll notice the muscles just let go and they relax because you're providing this input of safety, where they have the permission to let go because they know it's safe. And so that isn't true tightness where you need to work on like stretching out, let's say that bicep muscle. It's more about connecting to be like, oh, it's okay. And so that is a big piece during pregnancy for women who have, for example, pelvic girdle pain, or, just had it even pre-existing and didn't realize it was happening. And so that connection piece is important during pregnancy because it optimizes their pregnancy and then going into birth, which is a big piece of what I do as well. And pelvic girdle pain isn't just during pregnancy, it's also postpartum. I do see it fine during pregnancy, and then after having, example, a traumatic birth experience, then they come in with that pain, and they're like with walking, with going up the stairs, rolling out of bed. And if you are listening to this and you're experiencing it, one really simple tip that can make a really big difference is your breathing. And we talked about how breath is so important and how it's connected through our inner core unit, but it's what I call blow as you go. And so as, let's say, you're rolling out of bed, breathing through that movement, because what we do is, I want to protect everything, and then we try to roll, which is just pressing down and increasing pressure, but we're not using our body and moving fluidly, which goes back to that novel piece and just doing simple movements that allow our body to feel safe and move, because motion is lotion, and that's how we get things moving again. So that's pregnancy-related pelvic girdle pain. Now,
Wow. What's remapping?
yeah.
What's the process of remapping?
So I really wish I had a pelvic floor model, but I'm at home, so I'm not in the clinic. I don't have it with me. But essentially what it would be is, so we know our pelvic floor has 3 layers. The first layer of your pelvic floor is actually the outside. So if you think about, you have your 3 holes, the urethra, you have the vagina and the rectum, you would first start on the outside, and I would gently just be feeling along those tissues on the outside. There's 3 muscles around there. They're very fancy names that I won't go because you'll just be like, huh? But you would go through those tissues, and what you're looking for is an analogy that I use that works really well is think of a steak, a well done steak versus a raw steak. So a well done steak, if you were to press on it, it would feel pretty taut and kind of tough, versus a raw steak would feel soft and kind of squishy, for lack of a better term. And so as I'm working through the pelvic floor, whether it's that first layer on the external or then entering at the vagina and working my whole finger inside, I'm looking for that sensation. Is there those taut, stiff muscles that aren't letting go? And is it just tension where I say, okay, here's a spot, and they'll say, yeah, like I can feel that, or actually they would just tell me like that's burning, that's pain, that's discomfort, any of those pulling, any of those feelings. So we hold that spot, and I'm just doing a gentle pressure. I'm not trying to do like trigger point release. Research has shown that intense trigger point release isn't the answer, because what happens is we're creating more of a pain response, right? More of that pain is being sent out as an output. And so then what happens? We contract and protect more, which kind of just keeps going. So it's a gentle pressure that you can feel it, but it's not like a 10 out of 10 pain. Really, it should be no more than a 3 out of 10 pain. And then what you're doing is getting them to learn how to do a flower blossom technique. And so that's what I like to coin as like a reverse Kegel or core breathing, which is really just working on the movement of the pelvic floor. So we talked about it last time where we inhale, our pelvic floor lengthens and relaxes. We exhale, it comes up. So with this flower blossom, you're really thinking of a flower blossoming where the vagina is, and it's kind of opening up to allow those tissues to spread up and then to come back in. And as they do that, sometimes I provide some other techniques over the abdominal region to just help distract that sensation, and giving them a chance to feel this new sensation, which almost always is, oh, this doesn't hurt anymore. And so they keep breathing for about a few minutes, and then I take away my hand if it's elsewhere, and they stop their breathing, and my finger's still there, same pressure, and they're like, oh, pain's gone. And that's just tension, for example. And then I would keep working through that. And
Wow.
and so part of it is just learning that it's safe, and again, giving the permission to let go. And I always tell my clients to repeat the mantra that it's sore, but it's safe, and giving them that opportunity to connect with their pelvic floor and know that, oh, okay, everything's healthy. The tissues aren't damaged, because so often that's what they think, especially postpartum when they've had a traumatic birth. It's, this isn't safe. I'm so scared. I had a traumatic birth. I don't know what's happening. They haven't processed their birth. And so giving them that opportunity to know that, oh, everything is actually okay, because when they go for that OB check-in or their midwife and they're like, yeah, you're cleared for sex, they're just like, no, I'm not. Like, there's other things going on. And that's where this happens, whether it's, postpartum, what I just mentioned, or during pregnancy. So pelvic floor remapping is a manual technique that I use quite often throughout perinatal care.
Wow. And so would you be, if anyone with pelvic pain, would there be like the tension you're talking about, like around the vagina? Would that also then mean you might have pain higher up? So is it like a connection there?
So let's say in their back or their kind of hips higher up. Is that what you mean?
Yeah.
Yes. So there is a research study that came out of, I don't know how many years, a few years ago now, and they actually said women who have low back pain, I think it was about 80% of those had pelvic floor dysfunction. So there is a known fact that there's a high correlation between back pain and pelvic floor. And by working in the pelvic floor, there can be huge changes in the low back. Mind you, it's not just this pelvic floor remapping. It's, again, going back to that nervous system and pain science and then the lifestyle interventions. Like, there's a lot of pieces to it. But yes, you're right. Like, there is a huge correlation and connection between it because it's our body. It's all related to each other. And it's about, again, bracing and holding on to that tension.
Wow.
Are you giving your pregnant clients any tips on how birth could be done a little bit easy? Can I say easier? I'm not sure if I can say that. A little bit like the positioning with the breathing, the positioning, also tearing.
Yes.
Is there any control over that?
Yes. So there is some good research now to substantiate that. So that is a big piece. So usually, as they get later on into the third trimester, it's good to actually have this conversation with a pelvic physio before 35 weeks because often 35 weeks is, at least in Canada, I don't know how it works there, that's when they go back to their OB and say, okay, this is what's going to happen. This is what I want. So it's nice to have it at 34, 33 weeks so you can advocate for yourself because what I see is, so there's now the Society of Obstetrician and Gynecologists came out with new guidelines based on research, what is recommended during spontaneous birth that is not a high risk birth or pregnancy. And this was now like 5-6 years ago, but it's almost always not in practice because gynecologists and OBs have been in practice for many years most of the time. And they've been trained one way that isn't the most evidence-based. And we know that usually takes 10 years from research to be put into practice. So this conversation is so important and can have such a difference, if not for necessarily even just how the birth goes, but just being informed about what decisions you can make, because so often what's so hard and what I hate to see and happens all the time is that women come postpartum and like, I had no idea. I wish I could have had more control and just, been able to advocate because things just happen and that informed decision isn't truly there. And so the more you know, the more you feel empowered, and the more you feel empowered, the better it will go. But there are things physically that can make a difference. So you mentioned positions. That's a huge one. And a simple tip that makes all the difference, what research says is a sacral freeing position. So we know on our back you have your spine, then you have that kind of triangle bone, and then your tailbone at the very bottom. So that triangle bone is called your sacrum. And often if you've ever watched movies or like you think of birth and delivery, you think of, lying on your back, feet on the stirrups, and kind of pushing in that way. The reason why that lithotomy position came to be was way, way, way back in the day. They just wanted to make it easy so they could see what's happening. And I think it was like a king who wanted to see the delivery of his babies. And so that's how it kind of started about. But that isn't the best position for birth because, do you want to mention something?
I am shocked. I am shocked.
Yep.
A king wanted to see his baby coming out.
Yeah, that is where it originated from. He just wanted to watch the delivery, and so he wanted to have a good view.
And it's still around.
And it's still in all the movies I see.
Yep, and that is the way to have birth. But yet it's known that when you have your sacrum against the bed, so you're lying flat, that actually closes your pelvic inlet, sorry. So when you have your back down, especially with your knees out, that space where baby comes out of is smaller. So physiologically, it's harder because your pelvis can't really move a lot. It's kind of stuck to the bed. And so doing a position where the sacrum is free is what makes the difference in that space where baby comes out of. So it depends too on.
How would you do that?
Yeah, so it depends, right? If you get, let's say, an epidural, often you're not allowed to move very much in bed from a safety perspective because you don't have the same sensation in your legs. So I'll talk about positions if you get, let's say, an epidural versus not an epidural, because there's both. So if you are to get an
You're
epidural,
amazing.
so if you get an epidural, side lying is beautiful because that sacrum is free, that top leg can move, and it's just also sometimes more comfortable than being in one position the whole time. And so having that top leg bent with the knee close to the chest, bottom leg straight, you could put, do you know what a peanut ball is? They're like kind of like two halves to it. No. Anyways,
We can imagine a peanut.
yeah, so it's kind of like
Yeah.
those big Theraballs, but instead of it being a ball, it's in the shape of a peanut, and you can put that between your legs so it's supported. Or you could get your midwife or your partner or whoever else is there at that time to support you to hold that top leg. And if anything, what's also important with that is bringing your knees closer together than knees out. When you bring your knees in closer together, it opens the space in your pelvic region, as a contrary to what you would think. When you rotate out those knees, it actually closes the space where baby comes from. So you almost want your top leg bent higher in, kind of turned this way, if that makes sense, and then your bottom leg straight. And that is an easy position. So just lying on your side, however way you want to make that work. Another one that if you want to lie on your back, and it's okay to lie on your back for periods of time. I always say birth is your biggest marathon of life. Like, right? There's so much that happens. Oh, did you have a question?
No,
No.
keep going. We are
Just
hanging. Yeah, we're
You
fascinated.
were hanging on your words.
Yeah.
This is
I'm gonna save this podcast.
These are so helpful, these things. Okay, so I was talking about side lying. That's one really easy one. And then, if you lie on your back, that is a-okay. Like, that is fine. You need some times where you need to switch positions. You can't be in one all the time. Like, it's just hard on the body. So if you are lying on your back, get 2 towels, roll them up, kind of a nice long roll, and you're going to put them on your sit bones. So if you were to kind of reach where your bum is, you kind of feel those bony parts on either side of your bum. And if you put 2 rolls on either side of that bony part, if you kind of go right now, kind of stick your hands right where your bum is, kind of curved on the inside, you'll kind of feel those 2 bony parts. Those are your sit bones, which the technical term is called your ischial tuberosity, where a lot of the pelvic floor muscles actually attach onto. And so if you put those 2 rolls underneath there, it creates a little bit of space where that sacrum isn't flat against the bed. It's just a little bridge. So even that can help if you have to do it on your side. Now, sometimes with epidurals, it depends on the level of comfort with whoever is your birth team at the time. They can let you do other positions in bed. So you can usually move the bed a bit. So you can bring, let's say, the top of the bed up and then put your arms on that side. So you're kind of hanging off the top, and then you're almost like in a modified, like, hands and knees position, if you can picture that, where your hands are resting on the top of the bed and then your bum is free floating, sticking out against everyone else. And so hands and knees is amazing. Up on your knees is amazing. Squatting, if you can then don't have the epidural, is amazing. There's some, like, dancing can help get, like, progress labor a lot faster too. So dancing is actually fantastic. A half lunge position if you don't have the epidural. Really anything where you're moving, and if you think about it, everything can move more free, the easier it is because everything can open a bit more. So there's a lot of amazing positions. Go ahead.
How much do you think it helps to do it in water? Because I've heard that before and I'm not sure, is that legit?
Good question. I don't think there's enough research right now to say it's better. I think from clinical experience, the women who do it in water are also just a lot more educated, and they know what they want for birth. And I always say it's not your birth plan. it's your birth preferences. And what's great about developing on what you want is you learn all these options. So again, you make that informed decision in the time. So maybe I recently had a mom that just came to me postpartum, and I was seeing her during pregnancy, and she had to end up getting the epidural, and she had to get oxycodone to help kind of speed up the process and other kind of hormones. But she's like, for instance, she's like, let me do some just natural like breast stimulation to see if I can progress my delivery. And she couldn't, but she's like, I had that option. They gave me that time. And then I went forward to having that other hormone kind of to help kind of bring on my birth. So just sometimes having those decisions help. But going back to that water delivery, I think the ones that have done it say it's amazing and it was like the best thing they've done. So I think there is some potential benefit to it, but it's hard to know for sure if it is. The nice thing is you have water, which calms you, and you're in a safe environment. That is one of the most important things, is being somewhere where you feel safe. And so often when you're in a hospital, you're hearing all this beeping sound. You have all these random strangers just looking up your vagina and just telling you to keep going. You're like, who are you? And like, like all these things that are just foreign can change how you feel. So, if you're in a hospital, having music that you want, like have a playlist that you like in advance, bringing your own robe that you're going to wear or clothes that you want, bringing things around you to feel more comfortable within the room. But when you do it at home or when you do it in the water, again, you're picking that environment. And if that's where you feel safe, well, then that's where that fear tension cycle comes in when we talk about tearing, where if we don't feel scared, we don't tense up the pelvic floor. And then as a result, everything's more open, which allows for better delivery. And I should stay away from delivery. I don't like delivery. Pizzas are delivered, babies are born and birthed. So there's that. But yeah, it's about feeling safe.
Yeah, definitely. It makes so much sense because I feel like so much of it is when it's not like, you're not taught about birth at school. Like, like the first time you really learn about it is when you do it. And that is when everything's kicking off and it's terrifying. And you're like, oh my God, what's going on? So if there's any way to relax, that makes I mean, I get that with period pains. Like my mum used to like when I because I didn't get them for years, and then suddenly I started getting them, and I didn't when I was in my 20s and didn't know what to do. And I was with my mum once. She just made me lie down in a yoga thing, like put loads of cushions around me, and just like it was just like relax into the pain. Like, and this is she was like, oh, I know this from having 3 kids. Like, like relax into this pain because it's not bad. It will go like, and just breathing through it. And so now it's that thing of like, I think, as you said before, it's like naturally we're like pain tense. Like, because if you're going to, in combat sports or something, that actually makes sense. If you tense, you're actually protecting yourself. Because if you get hit, like you can take the hit. But it's like, it's the complete opposite in this. It's like, relax.
And it's so funny because when I work with athletes, let's say who are fighters or high level athletes in other areas, they have a harder time because they're so used to protecting, and like that's a part of their practice. Or dancers are huge, right? Like holding your core and brace. And so it's kind of unlearning these things for this specific area. So it would be even more necessary during pregnancy and birth prep and postpartum. I've noticed that.
Yeah, that makes a lot of sense. So I mean, maybe they don't, but like, do athletes, people who, or not even athletes, like, well, athletes as well, but people who are very fit, people who stay in shape and sort of maybe train throughout pregnancy to some degree, is there a difference that you see between how they experience the like pelvic issues and birth and the stuff that comes after?
Yeah, for sure. So I would say those who are more active throughout their pregnancy and do continue with physical activity and movement, they have less, first of all, pain during their pregnancy and other symptoms. But also with birth, they're more athletically fit. So I find that they're able to go through that marathon a lot better and tend to have better deliveries and births. But I will mention sometimes, like I said, they have these habits that they're so used to from whatever sport that they do, and it's unlearning it. So if someone had pelvic floor physiotherapy or pelvic health physiotherapy during their pregnancy that helps them prepare and unlearn these things, and then they're in a great position. But someone who maybe is like a go-getter, used to being like hardcore and kind of did that and didn't know anything else about, relaxing and lengthening that pelvic floor, then that might actually make it harder in labor because their pelvic floor muscles are in a contracted, intense position and they haven't learned how to connect with it. So yes and no. I think activity and moving through pregnancy is of the most important. So I think that sets them up for success, but it's kind of guiding how much and what does that look like, and also connecting with that pelvic region, because we can't forget about that piece that is often the missing piece of a lot of the puzzle, right? The other thing I did want to mention when we were talking, about birth positions and tips to help is breathing. You mentioned breathing, and I want to hit on that because it is very important. And you'll see so many types of way to breathe during labor. And what I always recommend is breathe how you feel like you need to. The only thing that is important is you have an open glottis. So a glottis meaning we're not doing that Valsalva maneuver, which I see with a lot of power lifters, where they do the and they brace, kind of going back to that constipation conversation that we had. Same thing, right? We need to be opening your breath. So screaming, saying like any of those movement and that breath actually goes down into the pelvic region to allow everything to open. If you want to try a simple exercise, if you put your hand on this part of your neck, there's like a little bone there. And if you were to do so I want you to try a high hum and a low hum and see what you notice in this region.
Are you ready?
Yeah. Okay, I'll do it with you. Ready? So let's try a high hum. And then a low one.
If it's smaller, I mean, that's your voice box, isn't it? So it gets smaller when you go higher.
Yeah, so there's a little bit of that.
It goes higher when it's higher.
Yes, that's the big piece.
Wait, say that.
So when you
go higher, it goes up. Or is mine broken?
No. You got it. That's it, right? So when you do a high hum, it goes up, and when you do a low hum, it goes down. And that's exactly what's happening in your diaphragm and in your pelvic floor. It's like 3 layers of the diaphragm. And so it goes back to just breathing, humming, screaming, like any of these sounds during labor is actually a good thing because you're opening the glottis, you're not pressing down and through the pelvic region, and you're allowing the pelvic floor muscles to open up. So breathe as you need, but don't do what nurses tell you all the time to, okay, hold your breath and bear down, go for 10 seconds, because that is what I hear all the time. And so having these conversations in advance can set you up for success as well, so you can advocate to the OB what you want to do during that piece of time.
But why is the advice? I mean, you said before it takes 10 years for research to sort of like filter down, but is that what it is? It just hasn't, this information hasn't yet filtered down.
Yeah. So when I was talking about the recommendations from the Society of Obstetrician and Gynecologists, that is one of the many. So one of them is labor position that we talked about. Another one is breathing and, trying to breathe as they would like and not doing the Valsalva maneuver, which is what I just mentioned, that bearing down. There's other things like, being able to drink and have food. I said it's the biggest marathon of your life. Why are you limited to just ice chips? You should be able to drink and eat throughout, right? That's one that they've noticed as well. Having a doula. So I don't know if you know what a doula is, but they're essentially someone there with you to support you during your labor. They can advocate for everything that you want, and they're not a medical professional, so they're there to support you. And there is like the highest level of research, level 1A out of all the different stages, that they can make you feel more safe, comfortable, and have a better birth and delivery. So that's one thing they also recommend in there. There's a lot of other things like declamping and waiting to at least 60 seconds before declamping the umbilical cord. So there's a lot of stuff on there, and I can even send you like my top 10 tips if you want to upload it somewhere afterwards, because it's substantiated in research, but the unfortunate thing is so often it isn't in practice because this is things that have been done for many, many, many years, and that's just how they were taught. And so I think it's about, starting at medical school and those OBs and teaching them, like, this is your pelvic floor, and these are some things that you can do. But there's a lot of upstream work that needs to be done for that.
Definitely. We'd love to be able to publish something like that, just because me and Marina's mouths are just like gawping.
Yeah.
Like, we're so like, wow. And I'm sure there are a lot of people who need to know this.
I'm kind of not I don't understand. I mean, in order to go into the delivery room and be prepared, you do need to have a few conversations with the team before. What am I going to be doing? Do you know what I want? Like, for example, the epidural that you said.
Yeah.
Is that something that is, do you choose for it in advance? Or is it there if you feel that is too painful? How does that work?
Yeah, and actually that's a good piece to talk about pain management, because there's a lot of different ways to manage pain during birth. And there's actually a really good resource that's called Evidence-Based Birth. And it's a midwife who has all the research about delivery and breathing and pain management and different ways to go about it. So it's a great resource for anyone listening who is pregnant or wants to just learn more about it for, let's say, their second birth. The way the epidural works is it depends on how far dilated you are, and you have to be early on enough that you can say, yes, I want it. And if you wait too long, then you can't get it. So I think it's a conversation that can be had during your 35 week, like, I am thinking about it, or I'm not sure, or I'm definitely no, or definite yes. Sometimes that changes, right, when you're in labor and it's like, this is just too excruciating, I need it, and it goes well with it. What research has actually shown with epidurals, it slows down the second stage of delivery, the active phase of pushing, because you've now lost sensation and you don't know when you're having contractions. And so as a result, you're pushing without knowing whether or not you have the contractions. So there has been some research showing that, if you can manage without an epidural, it speeds up the labor and that delivery phase. But some women need it and have a great delivery, and it's fine. So it's not that there's one perfect answer, is that there's a lots of option, and knowing that you have these options. Another great way for managing pain is a TENS machine. So you may have heard of TENS machines for other orthopedic issues that it's like a machine that vibrates, and it's like a temporary Band-Aid solution for pain management. That can be something amazing to use during birth and to help kind of distract you. Acupressure, just teaching your partner acupressure points to help kind of relax you, can be great. Essential oils to help calm you down. Again, music, like all these different, and then there's also different specific physical types. So like there's laughing gas instead of an epidural. There's a lot of pain options. It just depends on your birth provider, what they're comfortable with. And so saying, what options do you have for pain? And what can be my options? And this is what I'm thinking about. And so if you don't go prepared, these things don't happen. And so it's having these these prenatal kind of birth seminars or webinars to learn about it. So when the time comes, you can be informed, and then you can advocate for yourself earlier on, or your partner can, because that is what sets you up for success. And that is what allows for, a better birth where it's not traumatic, because you feel that you have made these decisions.
Mm-hmm. Absolutely. Oh my God, there's just so much. I think one of the biggest things that it seems to be the problem a lot, that you don't know where to find help, find advice. I mean, this evidence-based birth thing sounds fantastic. I'm going to have a look. But I think knowing what, I think, this is the same with everything. If you don't know, if you don't fully understand something, you tend to trust the people who are in a position of power, who are the experts, the doctors and things. But actually, so often you have to ask for the thing that you want, but you just don't know to ask for it.
And you don't know what you don't know. Like, you think that's right.
Yeah.
You just go what they say.
Yeah, exactly. And you trust them, you instinctively trust them. But I think with these sorts of things, when the research hasn't filtered down yet, it's even more imperative that you kind of like have access to that kind of the information that you're talking about. And also it all makes so much sense. Like when you say it, it's like, yeah, I can imagine that helping. Oh yeah, I can imagine. But I would not have picked those things, like talking about like calming and like the essential oils and the sort of the acupressure and like making sure that you're in the right position and all of that stuff. You know, I mean, me and Marina just get all of our birthing tips from films, it seems, you know.
It's true.
Yeah.
It's true.
And also in the hospital, they wanna like finish off. It's not it's not that the experience is something very important that you need to, it has to go really well. It's something standard that they need to just move on.
Yeah. I mean, I was reading, I don't know if either of you know Adam Kay. He's like, he used to be a doctor, and he wrote a book, and he delivered babies. He worked in that ward, and it was just about his, like, I mean, he's a comedian now, so it's quite like dark humor, because it's, he's just literally running from room to room delivering babies, like with just like in and out, like, and you're just like, wow, he's like delivered 20 babies in a night or something. You're like, oh my God, like that's so they really do have a lot going on around you.
Imagine going to Adam Kay. Imagine going to Adam Kay and being like, I want to have my leg inwards and I want to have music.
Yeah, and I wanna have a bath with essential oils, please.
And some acupuncture, thanks. Lea, I wanted to ask you, because I've had a conversation with an athlete friend of mine who's had 3 babies, and she experiences incontinence still. Is that normal?
No. It's common, but not normal. So that's the other area. There's honestly so much. We didn't even go into perineal massage and how that can help for tearing. But there's really so much that we could talk about. But I do want to shift a little bit and talk about things that can also happen either during pregnancy or postpartum. And sometimes you like 5 to 10 years postpartum, and they don't even realize that it's something that can be addressed. So incontinence is one of those big areas that I work with. And so there's different types of incontinence. There's the stress urinary incontinence. And so stress urinary incontinence is when you experience leaking with coughing, sneezing, laughing, jumping, exercise. And so the basis behind it is you have increased intra-abdominal pressure. So again, we talk about this inner core kind of thoracic pelvic region with a pressure system. It's all about a pressure system, essentially. And so when you cough, sneeze, laugh, jump, any of those things, you have increased pressure in through that intrathoracic region. And so if your pelvic floors aren't working optimally, it's not able to manage this pressure. And that's when you see the leakage. There's also urge incontinence. So that's where, I see it often postpartum, where they're going to the washroom all the time, or with, for example, bladder pain syndrome and interstitial cystitis, where they're going so often and they get that urgency, or they don't make it to the washroom in time and have those episodes of incontinence. That's the urge incontinence. And then you have mixed urinary incontinence, which is the combination. So the most common that we see, and what research says, is stress urinary incontinence. The second one is mixed, where you see a combo of the two. And then third would be just urge incontinence. And so all of those areas can be improved significantly, if not cured, with pelvic floor muscle training. And again, highest level of research to substantiate that, saying that it does cure, or if not, significantly improve quality of life. And so it goes back to that pressure system and blowing as you go and not putting pressure. It's about working on the strength of your pelvic floor muscles. So, after birth, our muscles sometimes are weaker. We've also carried a baby for 9 months, and things have been kind of stretched right as it needs to be. And a quick debunking myth: if you've had a C-section, does not mean you won't have pelvic floor issues. Just because it was a C-section birth, you still carried a baby for 9 months. The pressure was still there, that heaviness, the kind of restricted breathing because it's taking up space. So you can also experience it with a C-section. So that doesn't take you out of that picture. And so working through building the strength, the endurance, the coordination, that is so important. And even doing something like a knack. So a knack is where you learn to do a pelvic floor contraction before you cough, sneeze, laugh, jump. And that will help you so you don't have the incontinence piece and eventually become subconscious again. And you'll have increased control of that bladder.
Wow.
Yeah.
So much to look forward to.
Imagine neon belly after that.
Oh my god. No. Trampolines off limits.
Yeah.
Oh.
So people can, like, I mean, is it possible to completely bounce back after birth? Is it possible to sort of get back to a point where you're like, yeah, no, like my body is not, because you hear a lot of like stories about women who once they've had a baby, their body never quite returns to feeling the way it was they used to.
Mm-hmm. I think that answer really depends on a lot of different factors. And so it goes from, did you get pelvic health support, during pregnancy and then postpartum? Or are you just, oh, this is normal to leak a little bit. And I just, they kind of just go on with their day and don't realize it. And then, again, looking at their life. And so often postpartum, like you're struggling to sleep, to eat, like all these basic fundamental things. And so your body can't recover and heal if you're struggling with these basic principles too at the beginning. So it's making sure you have the sleep and you focus on what's important. And, chores will be chores. They will be there if you do them and if you don't. And so carving out that time for yourself is so important. And, not returning to, let's say, running postpartum, research has said now you should not be returning up until 3 months. And at 3 months, there's an extensive assessment that pelvic health physios do to see, are you ready? So if you are experiencing leaking or pressure with prolapse or a diastasis rectus, any of those things and other symptoms, you shouldn't be returning until you work with a pelvic health physio. And if you don't have symptoms, it's doing this assessment to make sure your body's ready to return at a gradual rate. But yes, I have women, especially athletes, who do great and go back to everything and are like, no, I feel amazing. And then I have some who struggle, or some who come to me years down the road and had no idea and have been there in this kind of in-between phase for so long. So there's so many parts to that, but I think, yeah, for sure there's that potential. It just depends on how active are you in your recovery. And some women have no issues, like they recover on their own, don't come to pelvic physio. Like my mom was an example. I was surprised when I started asking her these questions. Like she was fine, never had anything. And some women are lucky like that. But the ones that aren't, there's so much that you can do and still be in control of your health and reach that kind of either fully back to normal or significantly improved quality of life where you don't deal with these symptoms day to day as the same extent as you did before.
Mm-hmm. That's nice to know. That's really, I think also it's such an assumption that it's kind of, it's like an assumption that there are going to be problems and that's just the price that you pay. Do you know what I mean? Like that feels like often it's like, oh, it's just my lot. Oh, I haven't had a baby, so my body's just not going to, so then you don't seek out the answers or the help because you don't actually realize that what's possible.
Yeah.
And so talking about, like I think one of our questions was about painful sex and about how why and what's going on, and like go on. I was going to say like what, because there's different kinds of pain, isn't there? Like, and for very, very different reasons. So it'd be good to sort of like talk through and how that relates to pelvic health as well.
And also, would the positions that you described just a little bit before with birth, would that apply to sex too?
In a different way, yes.
Right.
Okay, so when we talk about pain with intercourse, there's a lot of different reasons why it can happen. So if we're looking at the postpartum population, for example, some things can be hormones. After having birth, your estrogen drops. And so the vaginal tissues are not as plump and they're also more dry. So lube, you need to be very generous postpartum, and even maybe a vaginal moisturizer that you can usually get off the counter to help plump up those tissues, because that can make a big difference from a physical standpoint. The other thing is scar tissue. And so let's say you've had an episiotomy, or you've had birth and you had some tearing and you've had stitches. Just like any other surgery, or a C-section, same thing, C-section, you have scar tissue in that region in which there's adhesions, in which things are kind of glued and stuck together and aren't moving free. And so with the insertion of the penis, if it's rubbing on that scar tissue, that can actually cause discomfort in that physical sense. So scar tissue massage postpartum is also important. And then if you've had a traumatic birth experience, or you're afraid and scared, or there's pain, or like in your back or other areas, again, pelvic floor tension and tightness. And if everything's contracted, imagine a penis going inside it at that state. That's going to hurt, and that's going to press on these tight muscles or tense muscles, which is going to contribute to that pain. And so that's where that pelvic floor remapping piece comes back in. So that's just some reasons for postpartum. There's a lot of others, but those are the big ones. And again, just because you 6 weeks check like you're cleared for sex does not mean it. There's also the libido piece. Like, are you tired and like just don't have the energy, or like don't feel sexy? Because that is so important too. And you need that time to lubricate and naturally have that foreplay, which is hard now that you have a newborn baby crying all the time or needing that attention. And so again, the environment and setup and that intimacy connection with your partner is so important too, that it takes time. And so at 6 weeks, you don't need to have sex. Like, that is not meaning to go forward. It's checking with a pelvic health and looking at other aspects, because the OB will only look at, have the tissues healed? Is there an infection? If not, you're good. We're looking at everything else in that sense. So postpartum pain with sex, that's kind of those big areas. I can go in more, but I'm going to talk about the other types as well. So even without having a baby, there is vaginismus, for example. And so that is the difficulty to actually have insertion through the vagina. And so that's like the spasming of the pelvic floor muscles that is not allowing the entrance. And that is difficult. That is something very common. I work with actually the younger kind of 20 to 30-year-olds pre-baby area. And there can be a lot of reasons as to why that started. And so things like, some other traumatic experience with their kind of urogenital region, whether that's sexual abuse or any other surgical procedures, those can have huge impacts. And so getting to the root of that problem and, pelvic floor remapping, working through the pain signs, your nervous system, those are all really important pieces. So that's vaginismus. There's also vulvodynia, which can contribute to painful sex. So that is actually just pain in through that vulva region. So contrary to what everyone calls your vagina, this is an anatomy 101. Your vagina is not that whole area. Your vagina is the hole where you have sex and where baby comes from. Your vulva is the whole area. Okay. And so vulvodynia is pain throughout that area. And there's some specific, more anatomical terms to describe where the pain is rooting from. But I don't like using these diagnoses because it doesn't really matter that much. It's more about addressing kind of how can we work through your symptoms and getting to the root of those problems to help you feel more comfortable, safe, and giving that permission again to let go. And pelvic floor physiotherapy and pelvic health work is like really great and helps a lot. And then there's work with dilators and accommodators that can also go into that picture. So there's those pieces. And then there's also just like pain with deep penetration, which I see. And so that is if you have a partner with a really big penis, because that happens. And oftentimes those are the women that also have vaginismus. It's just the luck of the draw, the way it works out. Or again, postpartum, and then you just have some tight muscles in certain areas, or just guarding on and holding that tension. And so positions do make a big difference. So I find it depends. Like, it really depends on the person. But for some women, like having their legs all the way up, that hurts because it's really getting into those deep pelvic floor muscles. Sometimes on your hands and knees, again, goes really deep into that doggy position, gets really deep into those muscles. And so I always say for women, one of the best positions to start with is you on top, because you control the rate of how fast you're moving, the level of the depth, the angle and the position. You are in control and you can kind of navigate that. Now, it's different and it's not always the case, but it's always a great stepping stone, and remembering to have that foreplay. That foreplay is so important. And as women, we know we need that time to become naturally lubricated and more circulation to be happening through the vagina and the vulva area. Like, we need that in order to be able to orgasm afterwards. And even more important if you're having any of this pain with that area, because when everything's so tight and constricted, the circulation isn't great down there. And so learning that flower blossom technique, and even like with the insertion of the penis or whatever else, doing your flower blossom, relaxing your pelvic floor helps so things feel safe again. So those are kind of the areas of pain with sex. I didn't dabble too deep. I don't know if you have any follow-up questions with either of those, or how to address it specifically with any or all of those regions.
I don't know. I think what you're saying makes a lot of sense. But I mean, why would the muscles so deep, they'd, if be so tight? And I guess like how to, because you talked about the vulva, and that what you said makes sense with the mapping. But then like this is the other way around. So deeper, would it then be sort of breathing techniques that you talked about before? Would you then do that around it, or would it be something that you do during it?
Yeah, so
Do you know?
kind of both. So the pelvic floor remapping, we also work with the deep pelvic floor muscles. And so first you start on the outside where the vulva is, and then you work your way in. So, you go to the first knuckle, you go to your second knuckle, and when you're in the third knuckle, you're in the deep pelvic floor muscles. And so same thing, I would find those spots and see, well, okay, we're guarding here, we're protecting it. Let's learn to let it go. And sometimes we do need to do some gentle massage work at the same time internally, to, if it is true hypertonic pelvic floor muscles and they're tight, learning to relax it and kind of stretch that out. So that is a piece of it for sure. The breathing is important because we're essentially, when we breathe and we inhale, we're lengthening that pelvic floor. So regardless if the pain is coming from the outside or the deep muscles, by learning to relax and lengthen your pelvic floor, and sometimes having my finger where that spot is helps them to tune in, and it's like, okay, now let everywhere around my finger just melt away and let it just let go. And sometimes it works and sometimes it takes practice, right? But also doing your breath during intercourse can be helpful, because sometimes it's also past experiences. So often, like, okay, I always have pain with sex, especially in this position. And then if you like warm up, you have lube, you do all these things, and then everything's feeling good, and then I have women like, oh, I did it and it was actually okay that one time. And it's like, okay, well, what did you do differently? And it's because they did all these other pieces and they didn't associate it with the past experiences anymore. So if you have pain with sex in that position, or in general, you're like, oh God, this is gonna hurt, I hate this. What do? Again, we kind of just protect, we guard. That is what our body's meant to do. And so it goes back to those past experiences and kind of working through that layer, that it doesn't need to be that way. And this is how we make it feel better. Now, so there are some other tools that can be helpful.
Wow.
So there's like a pelvic wand, and there's something called an accommodator that I briefly mentioned. They're also known as dilators. And so they start with like really small sizes. So they're like the equivalent of, let's say, like a penis, and they have like silicone, they've got plastic versions, they have all these different types. And it can be a nice adjunct to pelvic health physio, in which they start with a small one and then they do that as homework, and they're starting to kind of work on the insertion to allow the vagina to actually stretch and be okay with that stretch, and work through those deep muscles if there are spots that have some pain with it, and learning that it's safe and it's okay, and they're in control. Like, they're deciding how big of an accommodator they are, and usually we start small and work to the size of the girth of whatever they would in intercourse or whatever else that would be. And that way they've done it, they're in control, they know how their body reacts, they know how to help it let go, and then they would move on to that piece afterwards. And then the pelvic wand is, I don't use that one as often, but it's essentially, instead of my finger finding those spots, you would do that yourself internally, find those spots, and then, okay, now I know where I need to work on, let me just let go and work on that piece, and doing that breath work and feeling safe again.
Well, it's so mental, like mind,
Yeah.
like psychosomatic. It's amazing. And it makes so much sense because, I mean, I guess, and I think in the last podcast we did, you were talking about oh, and it's gone. I'm having a blank. You were talking about like how it's psychosomatic and how where women hold their emotions. That's what. And I remember you saying it was the pelvis and the shoulders. I remember those
And
two
the
things
jaw.
stood out because and the jaw. Yes, that makes so much sense to me. And so it does make so much sense that if you've got could any sort of trauma or any sort of experience like that cause pelvic pain and then potentially an issue like vaginismus or one of the other ones you've mentioned? Would that be possible? Or would it have to be more localized?
No, I think it depends, right? And it can definitely kind of present itself there afterwards. Not to say that I haven't. I would say more typically, I see it with those pre-existing things, whether it's a sexual abuse or birth trauma, or they have other pelvic condition like IC or bladder pain syndrome or endometriosis, because those all predispose you to kind of have pain, and then pain kind of spreads. And we know about central sensitization, right? In which the body then is now sensitized and it starts to feel pain in other regions that it didn't before, because it doesn't take as much for pain to happen, right? So it's very common with those specifics, but it's not to say that I see it from some other things. Yeah. Or just even like other like laparoscopic or other surgeries, and then it just kind of transfers into that region.
How do you work with endometriosis? What is exactly, so do they come to you? Because we've heard that working with your pelvic floor helps, but can you tell us how does it help, and what kind of how often do they see you, and what does that entail?
So there's lots of different ways to help with endometriosis for sure. A big piece is even just painful periods, right? And so there's a lot of simple ways to help with that piece. So teaching things like a heat pack with castor oil over the abdominal region and different positions to help alleviate that kind of abdominal pain. There's a lot of things that come with endo. So things even like IBS. So looking at their diet and their constipation, their gut health, because we know gut health is so linkly to their brain as well. But specific with endo, one of the big things they say pelvic floor physiotherapy, and there's good research to support it, is similar to what we've talked about, right? Almost always they have increased tension or true hypertonic pelvic floors because they have this pain and they're protecting that region, right? They have similar kind of endothelial lining that's spread to other organs, and that's pain. And so it spreads to other regions. And so it's those muscles in that region are also holding and protecting and super tight, or that tension. And so it's connecting with that region, learning to let go, doing that breath work, tuning into the nervous system. So things like yin yoga and nature walks, all those pieces are so important. I'm remembering the whole person, because it's, again, not just the pelvic floor, although that's a big piece of it, and remapping the pelvic floor and knowing, endo is one of those things that it's going to be up and down. Like recovery is never like this with anything. It's always like this, right? And so having these strategies in place to know when you're having a flare up, what are the tools, what are the strategies that I can use as coping mechanisms? And so it's the pelvic floor specific physio to help address the pelvic floor muscles if they are truly really tight, and doing that self-internal pelvic floor remapping work and stretching and breathing and yoga poses. It's the nature walks and just allowing your body to decompress again, or the yin yoga. It's what food you eat, because food we know can be inflammatory. And even with IC and bladder pain syndrome, another thing, there are certain diets to eliminate because they can be bladder irritants. So things like tomatoes and wine and chocolate, those can all irritate the bladder. And so it's important to try to take those out. Yeah. So there's a physio in the States. Her name's Jessica Drummond. She's amazing, and she's a pelvic health physio, but she focuses on diet with IC. I know I went a little off topic from endo, but it's all similar, and how there can be there's such an impact in what you eat and the symptoms that you experience. And then stress management. There's a lot of research to say that, it's stress And so what are ways to help manage your stress? Because when we're more stressed, we have higher pain. And when we're less stressed, we have less pain. So whether that's journaling or reading a book or that yoga or the walking, and it depends on the person and what works for them. And so it's finding these things to help guide that person along with the specific physical manual therapy techniques that we also use.
Wow. Again, makes sense. And I mean, we've been talking to people about endometriosis because it's such an people often don't know what it is. I mean, I know what it is because I have friends with it, but if you haven't, if you don't know people with it or have it yourself, it's very unknown.
Yes.
And I think it seems like there are a lot of problems trying to find things that help. So if something like pelvic physio would help, that feels like that's amazing and really, really beneficial. And what about other chronic pelvic pain issues that might come up? I think you mentioned IC. What does that stand for again?
So interstitial cystitis, which is also known as bladder pain syndrome. They kind of are the same diagnosis, just different terms and how it's coined. And essentially, it's a chronic pelvic pain condition to do with the bladder. And there's a lot of different symptoms that they experience. So things like bladder urgency, bladder frequency, pain with intercourse, variety of different things. And it's very similar in the sense of how we approach it with endo, for example. But maybe the only difference is the bladder habits that we already talked about, I think, in our previous podcast, where you're looking at how to gain better control of the bladder. And so often these women have pain in their bladder, and so they do things like limiting their water intake because they know when they pee it hurts, even though they know they don't have a UTI. And so when you don't drink water, your urine is more concentrated, which irritates the bladder, which actually is worse, and that causes spasm and then can lead to leakage. Yes, as we all drink our water. And so things like that, and kind of these simple lifestyle and behavioral things can make a big difference, and working through it. But essentially, that's what IC or bladder pain syndrome is. And again, these women, because they have this pain, they're centrally sensitized. So their nervous system is, again, everything is shut up. It's much more sensitive and experiencing more pain. And their pelvic floor is also, again, guarding, protecting pelvic floor tightness or tension in through there. So same idea, working through those different regions, learning how to be in control of the nervous system, working on your diet, working on stress management. There, you can kind of see this trend, and it's very similar, although it's highly individualized on the person, because maybe they have good stress management and they're doing well, but their diet is horrible, and they know that there's some sort of food sensitivities, but they haven't addressed it, or they know that coffee really makes it bad, but they're so used to having it. And so then it's motivational interviewing and working with the client, okay, we know this is the problem, how can we make these small goals to start to work on it and go through that piece. And sometimes I have sessions with clients that we just talk and we don't even do any physical work, and then the vice versa. And they're both so important when working with this population, because again, it's not just the bladder, it's not just the pelvic floor, it's the whole person. And if we're only looking at one, it's not going to make a big difference. And research has now shown that, and that's why it's so complex, because there's so much more to the picture, and there's so many theories as to the causes behind it, and we don't for sure know, but we know that these strategies do help. And so it's how can we help manage our symptoms through these different parts.
Wow.
That's amazing. I've just remembered, when I was younger, within the last 10 years, I remember whenever I used to drink a coffee, my bladder would hurt. It would just hurt.
Really?
But I loved coffee. And I used to have it once every couple of weeks. I'd have a coffee, then I'd just be in so much pain. But I had no idea what was going on. I was just clearly I need to not drink coffee.
Yeah.
I was okay, I better leave out the coffee.
Yeah.
But it was such, and it was just no one really, it was just, there was no answer. And there was nothing I don't know, going to the doctor and saying, it really hurts when I drink coffee. They're then don't drink coffee.
Yeah, but you never know why.
Yeah, and you're like, but is there something going on that I should be aware of?
Yes. And I can actually personally relate to that. So when I was doing my physiotherapy degree, super high stress levels. I went on birth control, which is a whole other like conversation, and the gut permeability and how it impacts our body and whatnot. But I noticed when that started happening, I started having really crazy bowels that was like all over the place. I'd have pain all the time. And like if I drank coffee, like my body would just like react horribly. I would just, something's wrong and I didn't know what. And my doctor's like, yeah, you might have IBS. There's not much to do. If you want, we can do like an endoscopic kind of thing to kind of diagnose it. But really, you kind of just have to live with it. And I was like, I'm not okay with this answer. Like, this is not enough. And so then I went to see a naturopath because, again, I'm in the area, and she kind of helped me work through an elimination diet and learning I had a lot of food sensitivities like gluten and potato and corn and coffee. And so coffee was a really big one. And I loved coffee. Like, I was a coffee drinker 3 times a day, espressos here and there. And I was like, oh, this is a really big thing I need to work on. And being a pelvic physio, I knew also coffee is a bladder irritant. And I also had an overactive bladder where I'd pee so often and I would hover on the toilet. I did all these things that I didn't know any better. Right. And so during school, I was like, oh my God, like, why does no one talk about this? Like, I thought this was normal, which is why I'm so passionate about it. And so through it, I now know there's certain things that trigger. So coffee, like you said, same for me. Like, I love it. I have it maybe once in a blue moon, but I try to limit it. And so things like that, when there was family gatherings, those days would be like, I knew I'd go into bed after and be like a mess because you have gluten, you have this, and then your body just reacts. But at least you know now, and you know how to help it. So naturopaths are amazing when it comes to this, and they're so knowledgeable about your gut and how to, help kind of improve your microbiome. And that's such a hot topic as well, and trying to improve that piece too. But you're right, like, you don't know until you don't know, like, you don't know anything, and you're just like, oh, okay, I guess I have to live with this now, like, or I just don't do it, but I don't get why. And knowing why makes such a difference.
Absolutely. And what you were talking about, you don't, I think you said, don't go, in the last episode, you said, don't go for a wee just in case.
Mm-hmm.
And I've got friends who wee like every half an hour. And it's like, I'm more and more aware of it. And I definitely have done that before, but I think it becomes so habitual, and then you just don't question it. You don't realize it might have a knock-on effect on something else, or
This is the biggest argument. This is the biggest argument I had with my mom. So before going on a trip, she was like, everyone go toilet. And you're like, I didn't want to go toilet back then, but now I want to. Do you know what I mean? I never understood the people who just go whenever they say, oh, I need to go toilet. Do you know what I mean?
Yes.
It's the stimulus.
Yes.
Can I ask you about a grey area that
Of course.
that is not very discussed? So menopause. What is your role with menopause?
It's our favorite topic at the moment.
Oh, yes. There's so much when it comes to menopause, and there's, premenopause and then PMS. There's a lot, and we know that hormones shift, and we have a drop in estrogen, and there's different types of estrogen as well. But one of the big things that is so hush hush, and I love talking about these taboo things, so I'm happy you brought it up, is vaginal dryness. And it is very common when you reach menopause, but the stats are so low because women don't talk about it and they just live with it. And so I mentioned it with postpartum because it's similar, although postpartum is just for a small period and then things bounce back, especially after nursing. But with menopausal women, their vaginal tissues are not plump. So they're thinner and things are drier. And so it leads to painful intercourse for that specific reason. So it's so important. And there's such simple way to improve it with just a vaginal moisturizer, something like Gynatrof. And so I wanted to make sure I mention that because anyone who is listening to that can make simple but yet so effective difference. So that's a big piece. And then there's that whole piece as well about, mood swings and fatigue and hot flashes and all of these things. And hormones, there's so many hormones, right? The other hormone is cortisol that I talked about, like stress. And a lot of times at this point in women's life, they have a lot of different things going on, right? They usually have their kids moving on to university or leaving their house. They may be taking care of their parents. There's a lot of different stressors happening. And so there's a lot of adrenal fatigue, I find. So your adrenal gland is one of the organs that help a lot with stress management, as well as your thyroids. And so, although, yes, you may be having hot flashes, which is to do with menopause, women I find that have these really intense, perimenopause or menopausal symptoms is not just because of that, but it's their fatigue levels and their adrenal fatigue is so high because they are managing such high levels of stress with so much happening all the time. And so it's learning how to work through that, which again is all those pillars of health that we talked about before. So that is a really big piece too, because they're just on overdrive at this point. So that is a part that I want to make sure I highlight.
Mm-hmm,
Wow.
After talking about the king and science after the king and the positioning of
Yeah.
delivery, I was listening to a podcast on women in medicine. It was from the Science Museum, and the Guilty Feminist had a show on women in medicine, and it was said that for quite a while it was believed that women are not fertile after a certain age, because they're not attractive anymore.
That's crazy.
And that was the belief for a very long period of time. Not about hormones, not about it was. So they thought that women are not attractive, and that's why
That's crazy.
evolutionary they stopped making babies.
Wow.
Oh, dear.
That's crazy.
Yeah, that is completely nuts. What other issues are common for women who are going through perimenopause and menopause? That what's the one where I think you start to sort of fall out a bit? I think is it prolapse?
Oh,
Is that what it's called?
yes. So I was going to talk about, there's two common things that happen. Again, it can happen earlier, and then menopausal just brings it on more again, because you also have less estrogen, so the tissues aren't plump, so physically things change through that region. But for pelvic floor, what you mentioned, yes, is prolapse, and that's a big one. And the stats are actually pretty crazy. So even with like endometriosis, it's 1 in 10 women, and it's actually April month, which is endo month. So I wanted to mention that. But prolapse, 50% of women have prolapses. So it's actually very common. It just sometimes is more common at that stage of a woman's life. But of the 50% of women...
What is a prolapse?
Good. I should probably start with that. That's important. So you have your pelvic organs in a pelvic region. For women, we have our bladder, our uterus, and our rectum, right? And it's all in a very small kind of area. Like, we can appreciate how small that region is. And so sometimes there's vaginal, like birth can be a part of it. If you had like a hysterectomy where you remove the uterus, there's different obesity, there's different risk factors that can predispose you to pelvic organ prolapse. But essentially what it is one of those or more than one of those organs has started to descend into the vaginal canal and the opening. So there's different terms. So if it's a bladder prolapse, it's a cystocele, versus if it's the rectum coming up, it's a rectocele. And there's different stages of prolapse. And so stage 1, you essentially don't see it. Stage 2 to 3, you're starting to notice the descent, and it's just at the vaginal opening or coming out of the opening. And then stage 4 is when that organ has come right through the vaginal opening. And so I see this most commonly postpartum and then during menopause. Those are the two times. And it's something we haven't really touched on today, but it's a really big area of pelvic health physio. And so with that, of the 50%, only half of those have symptoms. So I want to say the women who don't have symptoms, really, it's not something to worry about. And I find sometimes even just learning that you have it can make you feel so fearful, like I have what sticking out of what? And so knowing that it is okay. uh,
Yeah, I'd be terrified.
Yeah. And that's a big part of it, the fear, which then you tense and contract, and then you have pelvic floor tension, and then it adds to the whole picture as well. But with pelvic organ prolapse, only a certain percentage of them have symptoms. So common symptoms, if you're wondering, like, is this me, is pressure in the perineum, like you feel pressure or a heaviness down there. You tend to notice it more at the end of the day, especially if you've got a physical job where you're on your feet a lot, because we have gravity and it's constantly pulling you down. And then again, it goes back to that breathing piece. Often I see it with power lifters, women, because they're doing that Valsalva for heavy lifting all the time. And it's a very hot topic. But I mean, if you have no symptoms and you're fine with it, then you do you, girl, and that's fine. But if you're having symptoms and you know it's not manageable and it's coming with leakage, then there's things that we can do to optimize your breath and work through and maybe change how you're doing your heavy lifting, for example. But your breathing mechanics, because what it's stemming from is intra-abdominal pressure. Again, pressure, that's where it comes from, our pressure unit system. And so if we're constantly bearing down, another one is constipation. If we're always pushing, labor, pushing, right? All of that is connected, then that is the pressure that goes into your pelvic organs and causes that descent. And so we need to stop doing that, because that is what's contributing to the downward descent. You also have your ligaments, your fascia, your pelvic floor muscles. As we age, we know if you don't use your muscles, you lose it, just like any other muscle group. And so it's the same thing for our pelvic floor muscles. So there is some actual decrease of muscle mass in the pelvic region. So it's important for women as they go through menopause to work on the strength of it for that in its own, not even with pelvic floor prolapse, although that's important too. And then, fascially and the ligaments, everything is a little looser. And so besides pelvic floor and pelvic health physiotherapy, there are also some other adjuncts that can be helpful. So there's something called an impressa. I don't have it on me, but it's essentially like a tampon, and you insert it, and it's this like little like cube type thing, and it actually slings up your pelvic organ, so it feels a little bit better, and it's actually good for stress urinary incontinence as well. So sometimes that's a nice, band-aid solution, especially for if you're, let's say, skipping at an exercise and you want to do without leaking. The impressa can be really helpful for that. There's some other external garments. So you have like compression biking shorts. That can be so helpful to give that support and pressure, not pressure, that compression through the perineum area, so it doesn't feel that kind of pressure and hanging area. There's this other kind of like almost like it's not like a thong, but it's called a VV squared strap mechanism, and it's kind of where it's like underwear, and it provides pressure, and then straps on the side that attaches to again give that external pressure. And there's also something called a pessary. A pessary is this, I'm honestly not the best person. I don't do it. Pelvic health physios do it. I just don't. And it's this plastic or silicone device that's inserted, and it stays in there for months to years, and they teach you how to remove it. And it's essentially slinging up the organ, so that way you're not feeling those symptoms and you can go on day to day. And it's a huge thing and makes such a difference for some women. And here, OHIP, which is our government system for health and coverage, does cover it, but it's like a 2 to 3 year wait list with a gyno. Whereas pelvic physios can like do it right now. Yes, you have to pay a bit out of pocket, but it's a huge thing that can be helpful. So those are adjuncts that can be huge with pelvic organ prolapse. And then there's pelvic floor muscle training to help get those tissues stronger and help sling it up as well. And there's really good research again to support that and how important it is. And then especially if you're menopausal, you need to make sure we use those muscles, because they do start to lose it if we're not using it.
Wow. That's and why does it happen again? Why do people get prolapse?
So different reasons. It stems from a lot of downward pressure into the pelvic region. So whether that's childbirth, where you're constantly pushing down, whether it's constipation and you're constantly bearing down to evacuate, whether it's you're lifting heavy all the time and you're always bearing down as well. Lots of different reasons that can be risk
So you're
factors.
actually like, because I guess it's in a way you're actually pushing out your own organs.
Yep.
Like quite literally.
Yep.
Wow.
Because you have, right, this thoracic region, that's the diaphragm. And so when we bear down, it comes down. More pressure here. Sorry, this is not working well. More pressure down there. And so that pressure then goes to your pelvic organs, which then is, like we have a hole down there. So for men, it's not the same because, yeah, they can lift heavy weights and do the Valsalva because they don't have a vagina. And anatomically, it's different. But for us, it can be important and something we consider. So how you're breathing through day to day and all these different components make a huge difference.
So how would you adjust a weightlifter's breathing so that they weren't putting pressure like that? What would you say to a weightlifter if they came in with prolapse and you needed to help them?
I think it depends. Like that's a very individualized question. And, like the truth is a Valsalva maneuver where you do that bearing down, you are going to be able to lift more because you're using your pressure and your breath to stabilize your trunk to lift heavier. And it's important to prevent low back pain. So in that sense, it makes sense. So if they are okay with it and they don't care if they have the leakage or the prolapse and they want to do heavy lifting and they're reaching whatever goal, then you do you, like that's fine. But if you're asking for someone who's experiencing and wants to improve it, is trying to avoid this Valsalva where they're and bearing down. So blowing as you go to some extent where you exhale on the hard part of the exercise. So maybe let's say you're doing a squat. You're going to inhale on the down part, exhale, contract your pelvic floor, and then come up from your squat. So, and it depends on the move. And, there's different variations of breath and it so depends on what we're moving, who the person is, what works for their like pelvic floor coordination. And so it's hard to say specifics, but it's essentially trying not to close our glottis and use our breath through the movement to avoid whatever symptoms they're experiencing. And maybe it's, stepping back the amount of weight for a small period to be able to train and then building it up. I don't like to put people in boxes and say, this is what we need to do to treat. And also like, oh, you're never going to be able to do that again, because that's the worst thing you can do is tell someone that. And so it's about how can we do it differently? How can we find ways for you to do it where it's easier and it's better for your body?
Mm-hmm. Definitely. Wow. I need to go away and think about all of this. It's just so much. You're like a fountain of knowledge.
Thank you.
About like things which I feel are so underknown. Don't know if that's quite how you say it.
We've talked about birth and menopause, and these two happen to all women.
Yes. I know, it's crazy.
And yet we don't talk about these, and we don't.
I think it's just so many of the things that you're talking about I've worried about at some point. Like I've heard about birth stories and I've gone, oh God, that's so scary. That scares the shit out of me. I don't want to give birth. Can we just not do that? Or like talking about menopause and people old in my life going through it. And you're like, wow, I don't want to have, there are things you're having to go through that don't seem fair, but you actually have a lot of the answers that I think are so. I think that if people knew where to find them, if they knew that I need a pelvic physio, I need Lea, then they'd be able to improve their quality of life so much.
Wow.
And I think it's getting better, truthfully. Like I said, it's a fairly new area of a physiotherapy profession. And I think it's coming out now and more people know about it, especially around birth. I find perinatal care, I'm noticing it more. But you're right. Like I think it's just such a taboo area and people don't know. And almost every day I work, people are like, why didn't someone tell me this? Like, why isn't this talked about? Like, I need to tell my friends. Or some women are scared to tell their friends because it's like such a weird topic. I'm like, you need to. And so it's just like you said, it's being comfortable to talk through these things, and it goes to society. Like, why do we hide this? Like, why isn't this talked about? Which is a more like bigger problem issue. And then where do we find these resources? Which is like, I feel like a big theme of our conversation over the last two podcasts.
Yeah, definitely. I mean, if there were a couple of things that you would tell your younger self, what would you say? Like, like from your own experience of like how common certain problems are, to like yourself 10 years ago when, like, or me 10 years ago when I, was having problems with coffee. What would be like 5 things that you'd be like, these 5 things will really like improve your quality of life?
Ooh, that's a hard question. I would say 1, ask questions. Don't be afraid to just ask. You never know what you're going to learn. And I think being open can make such a big difference, whether it's one person or a lot of people. I think looking at your diet and how you're sleeping are so important. Getting good sleep has such an important part of all of our lives, and sleep hygiene. So sleep hygiene, a good diet, getting your fruits and veggies, getting good water, stress management. Like for someone who's in school, and deadlines and pressures to get into a program or tests and grades, like that really took such a big toll on me. And I didn't know how much of a whole toll it took on me until now. And I wish I knew what I knew then to help. So I think learning to have these open dialogue conversations with others and know that everybody's going through it. Like it's not just you. And it's okay if you have them. There's things that you can do for it. It's just asking questions and talking to those people. So I think that's 3 that I've said. 4 is movement. So making sure we're moving in whatever capacity that is. And it's okay if it's just a walk. And it's great if it's, like martial arts or you're a gymnast or whatever it is. But our body needs to move. And when we're in school or we're working a lot, sometimes it's hard to manage everything. But putting you first, I guess that would be my last one. You need you time and you need to carve it out. So this morning, I know my day's busy. I went for a 10-minute walk and gave myself that time, even though I know I have a million things to do on my list, right? And I think that's everyone. It's not even just me 10 years ago, but knowing that 10 minutes will do you so much good and the other stuff will get done no matter what. But you put yourself and your body first is so important because you only have one body and one brain.
Such a good way to close it. And we wanna ask you the standard podcast question that we didn't ask on the previous podcast,
Yes.
because this is the end of the whole series. So, Lea, what are you fighting for?
Yes, I am fighting for opening up and changing conversations about women's health. So breaking all those taboos and empowering women on their own journey, whatever it is, for their health and their well-being.
Amazing. What an amazing thing to fight for. Thank you so much, Lea, for your time that you've given us. And I think me and Marina are just
forever grateful.
Everyone, don't bear down, guys. No more bearing down.
Yes, no, it's been a pleasure. You guys are amazing to chat with. It's like a ball of fun and laughing all the way through. You just made this so easy and I loved it. I truly did. And I hope it helps those listening. And if there's more questions, ask those questions. There are answers. And if there isn't, go to someone else. You'll find them.